Alrighty, class. We'll continue with Chapter 1. Chapter 1's long, I know, but we're moving good gains. So let's talk about how do we measure a joint, and this will definitely be on the quiz. Movement in joints. Some joints permit only flexion and extension, while others permit a wide variety of movements, depending largely on the joint structure. So we use a tool called a goniometer, and that's used to measure the amount of movement in a joint or range of motion. So if you had knee surgery, ACL, or shoulder surgery, the physical therapist will use a goniometer to measure your joint motion. So let's say you can bend your knee only 90 degrees, right? And then what we're trying to work on is to get it to 120, 130 degrees. So that would be a good goal to keep. So goniometers provide an objective measurement for insurance companies and for yourself, and say, you know what, I was at 90 on Monday, now I'm at 100 on Friday, so I'm making progress. Okay. Inclinometers may also be used, and that's usually to measure the cervical spine or the lumbar spine. You can measure inclinometers. So here's the range of motion. See that goniometer right here? So he's measuring the knee flexion. That's probably about 130. Okay. Now, if you see her calf and thigh gets in the way, so that's what we call the end range, a soft tissue limitation, right? So area through which a joint may normally freely and painlessly move, measured with the goniometer. Now, the goniometer axis is placed even with the axis of rotation of the joint line. The stationary arm is held in place either along the parallel to the long axis of the more stationary bone. So see, on the femur, this is the stationary arm, and the fibula and tibia, they move into flexion, so that is our moving arm. So then we read that angle right there. Okay. And a lot of times you can visually see that that's about a 130. I get a lot of students or interns come in, they're saying, yeah, that looks like about 30 degrees, 40 degrees. I'm like, how does that look like 30, 40 degrees? Right? So you want to look at, make sure it makes sense. Make sure, go review your goniometry and geometry, right? 90 degrees. What does 90 degrees look like? That's an L shape. It's definitely past that 90 degree mark. Terms are used to describe actual change of position of the bones relative to each other. So angles between bones change, but movement occurs between articular surfaces of the joint. Flexing the knee results in the leg moving closer to the thigh. Flexion of the leg equals flexion of the knee. So movement in terms describe movement occurring through the full range of motion or through a very small range of motion. Example, flex the knee through the full range of motion beginning in full knee extension, so the knee is completely straight. That's 0 degrees of knee flexion. And flexing it fully so that the heel comes closer or in contact with the buttocks, that's a roughly 140 degrees of flexion. So let's say begin with the knee in flexion 90 degrees and then flex it 30 degrees. So 90 plus 30 is 120 degrees. So in both examples, the knee is in different degrees of flexion. Begin with the knee in 90 degrees and then extend it, which would result in a flexion angle of 50 degrees. So you were at 90, then you extended it 40 degrees, now you're only in 50 degrees of extension. So these are easy quiz questions, easy math problems. Some movements terms describe motion at several joints throughout the body. Some terms are relatively specific to a joint or group. Prefixes such as hyper and hypo, hyper meaning more, hypo meaning less, can be combined with these terms to emphasize motion beyond and below normal respectively. So hyperextension is most common. So hyperextension, let's say you have a hyperextension of the knee. So we know that normal knee extension is 0. So if you hyperextend, you can go into plus 10 degrees of hyperextension. Okay, if you have elbow, that's 0, and you can go into plus 10 degrees of hyperextension. So you went 10 degrees more. So let me show you an example of that. So here's knee hyperextension, right? So you're going beyond. Normally it would be straight as 0. So now this is almost plus 15 degrees of hyperextension. Here's the elbow. It should be straight. Now you're going beyond that. Okay? How many of you can do this? How many of you can do this? This is very bad for your ligaments and joints because you're going beyond. So you don't have a lot of stability here. Now, let's get into movement terminology. How do we move? abduction, that means lateral movement away from the middle of the trunk in the frontal plane, raising the arms or thighs to the side, right? So abduction. This is adduction. This is hip abduction. This is glenohumeral abduction. This is glenohumeral adduction. Okay, so make sure you know abduction, abduction. So here's adduction. She's going in towards, movement medially toward or and slash across the midline of the trunk in the frontal plane. So make sure you know the movement and what plane it goes into. Flexion. So if you look at that, that's elbow flexion, that's wrist flexion, that's hip flexion, knee flexion, and that's dorsiflexion. So bending movement that results in a decrease of the angle in a joint by bringing bones together, usually in the sagittal plane. So elbow joint when the hand is drawn. So again, this is glenohumeral flexion, this is elbow flexion, this is wrist flexion, this is hip flexion, this is knee flexion, and that's dorsiflexion or ankle flexion. Now extension is straight, so this is glenohumeral extension, that's elbow extension, this is hip extension, knee extension. So straightening movement that results in an increase of the angle in a joint by moving bones apart, usually in the sagittal plane. So the elbow joint when the hand moves away from the shoulder, this is elbow extension. Make sure you know the difference between flexion, extension, abduction, adduction. Now circumduction, you just go in circle. Circular movement of a limb that delineates an arc or describes a cone. Combination of flexion, extension, abduction, adduction. Also referred as circumflexion. So example, when the shoulder joint or the hip joint moves in a circular fashion around a fixed point. Now diagonal abduction, so see he starts here and he's going away. So that movement by a limb through a diagonal plane from the middle line of the body. And diagonal adduction would be he's coming back, movement by a limb through a diagonal plane. So this is good. We want to train our athletes or train our patients to do diagonal motions because a lot of sports involve diagonals. These are a combination of planes and axes. External rotation, so he's going from here and he goes going out. So if you've had a shoulder injury, I'm sure you've done external rotation. So this is external rotation of the hip, and this left shoulder is in external rotation. This right is in internal rotation, right? So that's internal rotation, but this left shoulder is in external rotation. So what's the definition of external rotation? Rotary movement around the longitudinal axis, which is straight down here, away from the midline of the body, occurs in the transverse plane, okay, along a longitudinal axis. Make sure you know the difference between axis and plane, also known as rotation laterally, outward rotation, and lateral rotation. But in the literature, most of the time, you'll see it as external rotation. External rotation. So internal rotation, he's going in. Rotary movement around longitudinal axis toward the midline occurs in the transverse plane, known as rotation medially, inward rotation, and medial rotation. So difference between internal and external rotation. Now, terms describing the ankle and foot movements, you have eversion and inversion. Usually you get an inversion ankle sprain, but you can get an eversion ankle sprain as well. If you're sliding into second or third, you can get an eversion ankle sprain, turning the subtalar and transverse tarsal joints outward laterally in the frontal plane, standing with the weight on the inner edge of the foot. And then inversion, turning the subtalar and transverse tarsal joints medially. So let me show you the difference between an inversion ankle sprain and an eversion ankle sprain. So here's an inversion ankle sprain, the most common inversion, and then eversion. That can happen in basketball if you step on somebody's shoe or something like that. So again, an inversion sprain versus an eversion sprain. Most common is an inversion sprain. Dorsiflexion. Flexion movement of the ankle that results in the top of the foot moving toward the anterior tibia. Plantar flexion, extension movement of the ankle that results in the foot moving away. So that's dorsiflexion up and plantar flexion down. Pronation and supination. So pronation, so this is a good definition, combination of ankle dorsiflexion, subtalar eversion, and forefoot abduction or toe out. So that's pronated. So those that have flat feet, you see, so your arches collapse here. And then supination, you guys have high arches, combination of ankle plantar flexion, subtalar inversion, and forefoot abduction. So make sure you can describe pronation and you can describe supination. So let me show you what pronated feet look like, flat feet versus high arches. And shoes, and we'll talk about shoes a little bit later, and I'll give you a nice little introduction of which shoes are good when we talk about the ankle itself, because that's a whole topic in itself, and I don't want to rush over that topic. So I'll tell you which shoes to look for and which ones are good and which ones are not good based on your foot type. Okay, but let me just show you what pronation versus supination looks like. All right, so here's pronated feet, kind of like, you remember Fred Flintstone? So you have feet that look like Fred Flintstone, and there's certain shoes that are better for this, and then you have high arches, and there's certain shoes that are good for that. All right, so again, I don't want to take the whole day on shoes, but I will tell you, I will educate on that because that's a good topic, and we'll definitely discuss that. But flat feet versus orthotics, all that stuff we'll talk about in this class. All right, pronation versus supination. Again, internally rotating the radius so that it lies diagonally across the ulna, resulting in the palm down position. So that's pronation. Supination is palm up, externally rotating the radius so that it lies parallel to the ulna, resulting in palm up. So I always say, hey, sup, man, sup. So when you say sup, you always have your palm up. You're not going to say, well, sup, man, and have your hand down. So you can say sup. So that's supination, and pronation is down. Depression, right here, inferior movement of the shoulder girdle. Example, returning to the normal position from a shoulder shrug, and elevation, superior movement of the shoulder girdle. So that's elevation and depression. Elevation, depression. Protraction, forward movement of the shoulder girdle away from the spine. So that's protraction. And then retraction is, so spending most of your time on the computer, you're going to be in a protracted state. So every once in a while, try to squeeze your shoulder blades together, and that's retraction. So do about 20 of those every hour, and that'll help with your posture. Rotation downward, so you get downward rotation of the scapula, and then you get upward rotation of the scapula. And making sure you have that is very important when you want function in the upper extremity. So rotary movement of the scapula with inferior angle of the scapula moving medially and downward, that's downward rotation. And upward rotation is rotary movement of the scapula with the inferior angle of the scapula moving laterally and upward. Horizontal abduction goes in. Horizontal adduction goes out. Okay, so movement of the humerus in the horizontal plane away from the midline, so that's abduction, right? And the horizontal adduction comes in towards the midline. Scaption, movement of the humerus away from in the scapular plane. We like to do all shoulder exercises in the scapular plane. Okay. Glenohumeral abduction in a plane 30 to 45 degrees between the sagittal and frontal plane. So try to do all of your shoulder workouts in this scapular plane. And it varies between 30 or 45. So if you try it in 30, you get a pinching, well, go out to 40. And if you get pinching, go out to 45. So, but that's the range, and it'll keep your glenohumeral joint from impinging and you getting impingement. Okay, side movements, which are lateral flexion or side bending. Movement of the head or slash trunk laterally away. Reduction means return the spinal column to the anatomical position. That's okay, so lateral flexion, reduction. Palmar, which is flexion movement of the wrist with the volar anterior side of the hand moving toward the anterior side of the forearm. That's palmar flexion. And really you get wrist dorsiflexion, but it's really wrist extension. So this is, it's kind of a play on words here. You get palmar flexion, which is wrist flexion, but dorsiflexion is actually wrist extension. So that's extension, movement of the wrist in the sagittal plane with the dorsal or posterior side. You get radial deviation. So remember, rad means towards the radius, so radial deviation, abduction movement of the wrist in the frontal plane of the thumb side of the hand toward the forearm. Ulnar flexion or ulnar deviation is adduction movement at the wrist in the frontal plane of the little finger. opposition of the thumb, right? That's what makes us human, the opposable thumb. Diagonal movements of the thumb across the palmar surface of the hand to make contact with fingers. Reposition of the thumb, diagonal movement of the thumb as it returns to the anatomical position from opposition with the hands, right? So that's opposition, that's reposition. Opposition, reposition. So if you look at animals versus humans, you look at this chimpanzee, you look at the human, you look at the orangutan, the simang, the gorilla, and baboon, you look at their thumbs. Humans are the only ones with a pretty good sized thumb that makes it for opposition, so we can do fine motor control, right? If you look at primate hands, look at all the primate hands. Okay, it's very interesting how they use. So if you look at evolution, whatever you believe in, right? So the evolution, right? Chimpanzee, the bonobo chimps, the gorilla. Okay, so very interesting. But again, humans are the only ones with the opposable thumb that allows us for fine motor control, and that separates us. So, all right. Movement icons. These are just little visuals that you can see what scapular elevation and depression. I'm not going to go over all of these, but you can look at these. There's glenohumeral flexion, internal external rotation. I've already shown you all that. Elbow flexion, elbow extension. Make sure you look at these. Wrist extension, wrist flexion, thumb CMC flexion, thumb CMC extension, thumb CMC abduction, thumb MCP flexion. Okay, so make sure you know the difference between that, just if you can visually see it. Again, here's MCP flexion, extension, flexion, extension, so knowing the movements, what each one means. Hip flexion, hip extension, hip abduction, hip adduction. Because this is important when you're doing exercises, right? What's an exercise for hip abduction? What muscle is it going to target? When we target the hip, you'll say, okay, the gluteus medius does that. What does hip adduction? The adductor magnus does that. Which ones do hip external rotation, hip internal rotation? What muscles do that? Knee flexion, hamstrings do that. Knee extension, quads do that, right? What does knee internal and external rotation? A little known muscle known as the popliteus. Okay, ankle plantar flexion, ankle dorsiflexion. So plantar flexion is gastroc soleus. So knowing which muscles do that. Great toe, MTP, IP flexion. Cervical flexion, cervical extension. Lumbar flexion, lumbar extension. Okay, so physiological movements, flexion, extension, abduction, adduction, and rotation occur by bones moving through planes of motion about an axis of rotation. The osteokinematic motion is motion of bones relative to the three cardinal planes resulting from these physiological movements. So we study a lot of osteokinematic, right? Bone movement. Osteo meaning bone, kinematic meaning movement, so movement of bone. For osteokinematic motions to occur, there must be movement between the joint articular surfaces. Arthrokinematics, motion between articular surfaces. So arthro meaning joint, kinematics, movement of the joint. Osteo is movement of the bone. Three specific types of accessory motions. You get a spin, a roll, and a glide. If accessory motion is prevented from occurring, then physiological motion cannot occur to any substantial degree other than by joint compression or distraction. Since most diarthrial joints are composed of a concave surface articulating with a convex surface, roll and glide must occur together to some degree. So example, as a person stands from squatting position, the femur must roll forward and simultaneously slide backward on the tibia for the knee to extend. So this is an important concept. This is a great quiz question. So think about yourself going from sit to stand. As a person stands from a squatting position, right? The femur must roll forward, so it's forward, and simultaneously slide back. If it doesn't slide back, the femur would just roll off the front of the tibia. Boom. If not for the roll, the femur would slide off the back. If it doesn't roll, then it would fall off the back, right? So it's got to roll and slide. Ooh, some of you have had those ACL injuries. Well, that's a failure of rolling and slide. Whatever happened to RG3? That's too bad. And unfortunately, ACL injuries. Look at this. This is a non-contact ACL injury. And you're thinking, how does that happen? Well, you've got to have, unfortunately, some kind of limited movement at the ankle or hip that you're trying to get motion at the knee, and something's got to give. And usually the knee and the ACL give. Boom, boom. Again, non-contact. Non-contact. Now, if somebody runs into you, well, then you just have bad luck. But when you have non-contact injuries like this, so now why do people wear knee braces? Because they're trying to provide stability where their muscles cannot, right? So they don't have joint stability here. But think about it. Look at his ankles. His ankles are taped. So if you lack mobility here at the ankle, then you got to get it somewhere else. So more research has to be done about how much torque taped ankles play on your knee, because if you don't have mobility at the ankle, you got to get it somewhere else. So it just doesn't make, remember, joints they go from a mobility, stability, mobility. So if you have stable, where are you getting your motion? Something's got to give. Okay, so knee injuries here. ACL injuries occur when the bones of the leg twist in opposite directions under full weight. You like my side effects there? That was pretty good, huh? Torn ACL, ACL reconstruction. So usually after ACL reconstruction, your ligament actually heals to about 110% stronger of your original ligament. So you should never tear your ACL twice. If you do, then you have really bad luck. I'm sorry, but usually it heals 110% stronger. Spin may occur in isolation or combination with the roll. As the knee extends and extends, spin occurs to some degree. An example, 1, the femur spins medially or internally rotates as the knee reaches full extension.